Webinar number 17, and we are going to see differential diagnosis of wrist and hand pain. I have taken the two webinars now and I am taking the third now in straight succession. I welcome all these followers on the AOMPT Facebook page to come and join me on Instagram so that you can join for the webinar on the differential diagnosis of wrist and hand pain. Not only just pain, wrist and hand disorders, musculoskeletal differential diagnosis. Okay. Wrist and hand. The 17th webinar is part of the 100 webinars and also the main 10 differential diagnosis webinar series, the free, absolutely free, all the 100 webinars. Okay, Century Webinarathon from the AOMPT. Okay, the 1st December 2020 to 31st March 2021. Okay, so participants should not miss this free webinars and register with me on WhatsApp and then complete the tasks to get the free certificates. Utilize this glorious opportunity to celebrate the new year 2021 by empowering your skills and knowledge. So good luck to you all. Come and join me on Instagram for the webinar number 17, differential diagnosis on wrist and hand pain. You may be wondering, okay, today what happened to Senthil sir? Okay, so he's come all of a sudden live. I was actually facing a huge interruption in the internet connectivity. Okay, so whenever I was getting ready, I was checking the internet and it was not at all going live. Not only that 7 to 8 slot, it was also 9 to 10 slots. Okay, and Instagram, I have found that with even the least internet connectivity, also Instagram works live. Okay, really deserves a 5-star rating for that. Okay, but the point here is today the live connectivity could be better. So I thought, okay, I'll just because there are some what is called as some kind of a slogging behind we had, okay, in the schedule. So as per the dates which were announced for the differential diagnosis webinar package and how we are on track, okay. So and also definitely we should make hay while the sun shines. Okay, it's very, very important proverb. So when the net connectivity is good, definitely we should always go ahead with the exchange of information and knowledge. Welcome to webinar number 17, differential diagnosis of wrist and hand pain. Of course, when you are seeing the wrist and hand itself, remember hand is the largest area that is represented in the brain. Structurally, functionally, sensory cortex also, motor cortex also. Okay, so any problem in the hand, always central nervous system, and problems in the central nervous system could be reflected in the hand. So coming to autonomic, which is complex regional pain syndromes, the autonomic disturbances, pseudomotor, pilomotor and vasomotor changes are observed maximally in the hands only. Nervous system also, upper motor neuron, spasticity, okay, or the lower motor neuron, which is the weakness with the sensory deficits. It can come secondary to radiculopathy, it can come to peripheral neuropathy, it can come as entrapment neuropathies, which is like ulnar nerve, that is an axillary nerve palsy, or you have Saturday night palsy of radial nerve leading to wrist drop. Ulnar nerve lesions can cause the claw hand deformity, medial claw hand or the ulnar claw hand. Median nerve injury can cause the median claw hand, okay, which is lateral 2 digits. Claw hand specifically involves the MCP extension and IP flexion. Okay, intrinsic minus deformity it is called as, because the action of the intrinsic muscles are flexion of the metacarpophalangeal and extension of the interphalangeal joints. This is intrinsic plus deformity. This is also action of lumbricals, but intrinsic plus deformity occurs in rheumatoid arthritis, okay, and it could be associated with an ulnar drift, okay, the digits being shifted towards the ulna, okay. Continuing with the deformities of the wrist and hand, the most important deformity is the ulnar variance and the radial variance, okay, where the usually the radius is, the styloid process is more distal, okay, inferiorly there, So if ulna is longer, it becomes it will limit the ulnar deviation, and the wrist radial deviation will be more. Okay. So the reverse happens if the radius is too much long. Okay. What you see in the snuff box, anatomical snuff box where you palpate the scaphoid, is also the site of injury, fall on outstretched hand, scaphoid fractures, which can lead to complications of avascular necrosis. Also, fall on outstretched hand in an elderly will cause the Colles fracture, distal end of the radius. If it is a dorsal displacement, it is called as the Colles fracture. If it is a ventral displacement, it's called as the Smith's fracture. Colles fracture, you will fall like this with the extended wrist. Smith's fracture with the flexed wrist. Okay. You also have other fractures which can range from the Monteggia and the Galeazzi fractures. Okay. Although they can involve even superior radioulnar joint and also the elbow. Of course, when you talk about regional fractures, which is coming to the thumb or the metacarpals, Boxer's fracture is the shaft of the metacarpals, and the Barton's fracture, which is the intra-articular fracture of the base of the first metacarpal. Okay. So you have various injuries there in the fracture wise perspective. Okay. Named injuries, which is orthopedic surgeons, they have identified these fractures and they have named it. When it comes to wrist instabilities and dislocations, it's very, very intricate. There are numerous ligaments in the wrist, in the volar and also in the dorsal aspect. Crossly, intercarpal, any kind of two carpal bones, the ligament is got. Ligament injuries, remember, it can range from sprain, which is an acute injury, sudden injury. Strain is a chronic injury. Partial tear, complete tear. Okay, grade 2, grade 3, and then the grade 1. So that should be again differentiated, and also the intercarpal. Okay, because you stress two bones, the scaphoid and lunate, and scapholunate ligaments. So the same way, if all the major ligaments of the volar region, if they are going for a sprain and it leads to an instability, it's called as the volar intercalated segmental instability, VISI. Okay. The same way, dorsal intercalated segmental instability is there for the ligaments in the dorsum of the wrist. Coming to inferior radioulnar joint, okay, again it can go for arthritis, mostly post-traumatic after immobilization and then arthritis. Or the radiocarpal joint or the midcarpal joint or the carpometacarpal joint can go for arthritis. So you need to have the differentiation between various segments. In the trauma, triangular fibrocartilage, which is in the ulnar snuff box. Okay, it's exactly between the triquetrum and the head of the ulna. So that injury you can detect with the ulnar grind test. Okay, when you are doing ulnar deviation and then supination pronation with axial compression. Anatomical snuff box tenderness will indicate the scaphoid fractures. Okay. So that's about the trauma outline which can happen in the hand. Of course, you have ligament injuries. Sometimes it can come in the valgus varus ligaments, the medial and the lateral collateral ligaments of the metacarpophalangeal or the interphalangeal joints. Okay. Other ligament, which is the flexor retinaculum, it's a modified deep fascia, okay, which can again go for entrapment neuropathies. So in the hand, a vascular problem is also common. You have all the vascular diseases manifesting in the hand, be it arterial or venous. Okay. Autonomic also manifesting in the hand. Neurological deformities manifesting in the hand. An ape thumb deformity, where the thumb lies in plane with the other fingers. Okay, it is adducted and laterally rotated. So this kind of a thumb is called as ape thumb deformity. That is the secondary to the median nerve injury and atrophy of the thenar muscles. Intrinsic minus, intrinsic plus in rheumatoid arthritis. In rheumatoid arthritis, deformities of fingers, you have botanier deformity, okay, where extension of the MCP, flexion of the PIP, and extension of the DIP. Okay, and the reverse, flexion of the MCP, extension of the PIP, and flexion of the DIP. Okay, that is the swan neck deformity. If it starts from the metacarpophalangeal joint, it is called as fan neck deformity. Whereas if it starts from the distal interphalangeal joint flexion, then proximal interphalangeal joint extension, and then the MCP flexion, it is the mallet finger deformity. Mallet finger is because of the avulsion of the extensor digitorum tendon, the central tendon from the distal phalanx. Okay. So here we are, connective tissue disorders. It can cause even primary osteoarthritis, can cause nodes, which is Heberden's nodes and Bouchard's nodes in the proximal interphalangeal and the distal interphalangeal joints. Okay. Coming to the tendon injuries, thumb, okay, keeping here, and then you do the ulnar deviation, Finkelstein's test, specifically the tenderness of the abductor pollicis longus and extensor pollicis brevis tendons, which form the boundary of the snuff box laterally. That is the decurvance, okay, disease. It can be again tendinitis, tenosynovitis, tenovaginitis, okay, spectrum. Here thumb, it is the trigger thumb, okay, the flexor pollicis longus, synovial sheath, and you flex and you extend and then it gets locked, okay, after that tuck, snapping sound, and then it extends. Trigger thumb. Come to trigger finger, the same one for the other. It mostly comes in the third and the fourth digits, where the synovial sheath thickening is causing the locking with the annular ligaments. Okay. When you come to the other, maybe tendon injuries, cut injuries are also common. In the wrist, you have cut injuries which can affect multiple tissues. Leprosy, which can cause claw hand deformity, which can cause wrist drop, and an ape thumb, which is triple nerve palsy. Okay, it can happen secondary to leprosy. And you have this connective tissue, which is like palmar aponeurosis, dupuytren's contracture. Okay, so that's again another disorder which you have to keep in mind when you're differentiating the soft tissue perspective there. When you are seeing for intraponeuropathies, I was telling you about carpal tunnel syndrome. The three mechanical reasons for carpal tunnel syndrome is the dislocation of lunate, or the lumbricals proximal migration, okay, or the tenosynovitis of the long finger flexors like superficialis and digitorum. Okay, so these are the three causes for carpal tunnel syndrome. So it can be associated with texting, or it can be associated with gripping, or it can be associated with wrist movements of extension or flexion. Carpal tunnel syndrome is diagnosed carpal compression test. You can also have the phalanx test or the reverse phalanx test. You can do the neurodynamic test 1 and 2, all for median nerve. So that's why. Ulnar nerve enters the wrist pisiform, piezohamate ligament, the Guyon's canal, and then it comes to thinner muscles. So here, if occupations that involve ulnar deviation, vibration tools like carpentry, they get the inflammation of the nerve friction with the pisiform, and they develop what is called as the hypothenar hammer syndrome. Okay. So that's again an intraponeuropathy of the ulnar nerve in the wrist. Okay. So when you see for fascia, that is the palmar aponeurosis we have seen, tendon we have seen, there is no bursa in the hand. Okay. You have seen for tendon injuries, which can be even cut injuries, glass injuries, industrial injuries. So that usually gets operated, repair and reconstructions. Sometimes even reimplantation surgeries after traumatic amputations are also common. Congenital deformities of the fingers. It can be like an extra finger, that is polydactyly. It could be syndactyly. Okay, fingers can be fused. Arachnodactyly, the web will be like more distally present. Okay, it could be a deficiency of one of the digit adactyly. Okay, it could be even deficiency of one part of the segment, phocomelia, amelia. Okay, different congenital, absence of whole limb or part of a limb is also there. Club hand. Okay, that's also another deformity where you have with the pronation, and then you have the ulnar deviations. Okay, deformity there. So remember that it is like neuromuscular disorders can also cause the deformity in the wrist and hand. Musculoskeletal disorders can cause the deformities, And in musculoskeletal, you can have traumatic and non-traumatic. Then in traumatic, you see fracture dislocations, instabilities. And atraumatic, you see for the tissue-based like tendons, you see for fibrocartilage, you see for retinaculum, or you see for nerve, which is entrapment neuropathies. Okay. Trigger thumb, for example, is the synovial sheath. Okay, that inflammation and thickening. So there you are getting a whole picture here. Remember that a patient with the hand unilateral problems, and if it is only in the hand, still you have to screen for peripheral vascular disease. So you might do the Allen's test, okay, occluding the radial artery and the ulnar artery, and then checking for the palmar anastomosis. You might do a Nihedrin sweat test. You might do a volumetric test for the edema. Nihedrin sweat test is for the sympathetic function, autonomic function. And you can also rule out the radiculopathies, and you will do the thoracic outlet syndrome, the elevated arm stress test, or the AdSense test. Okay, so all this test has to be performed. Of course, neurodynamic test, which you should not forget. Okay, the commonly screening tests. And if you have early morning stiffness and it's not easing with movements, stiffness with fever, multiple joints problem, suspect the polyarthritis. So rheumatoid factor positive rheumatoid arthritis. If it is negative, it could be the other seronegative arthritis. If a patient is having the joint stiffness after a surgery or after a fracture, it's a post-traumatic secondary osteoarthritis. But if there is no trauma, there's nothing, but bilaterally the nodes are getting formed here. Okay, so that is the primary osteoarthritis. It's also very rare, but it can come. Okay. So what is important here is to get the holistic picture there, and then a patient with wrist and hand symptoms, try to evaluate this. There are sports injuries in addition to that, like gamekeeper's thumb. So you have the ulnar collateral ligament of the carpometacarpal joint getting strained. Okay, so there is a lot of ligament injuries which are mostly common, which are done with the strapping on field, and definitely patient recovers in a period of 3 weeks. If you are finding that the exercise program, what you are actually going to give for wrist and hand patients is the intrinsic strengthening. So working on the lumbricals action, working on the intrasi. Okay, so these are predominant. And then next, of course, wrist stability. Okay, because wrist is something which is multiple carpal bones, and to develop the motor control. So closed kinematic drills will definitely help in neuromuscular control and also the proprioception. Okay, so that's the outline. You might give what is called as the local treatments, but do not forget the central treatments, the graded motor imagery, the pain neuroscience education, everything, if the patient has hand symptoms. Okay, that is mostly common after the burns. It's after the crush injuries, okay, traumatic amputations and reimplantations. So all this will have central sensitization component. So do not forget to treat the patient as a whole and not just the hand. Okay. So again, I opened this session for questions. So I'll give another 30 seconds. I'll see for questions on differential diagnosis of wrist and hand, and so that I can read them and answer them for you, okay, during the interaction. Of course, ulnar collateral and radial collateral ligaments, okay, they are radial deviation and ulnar deviation. These are all traumatic. It can also go for injury. Okay, that's mostly after sports, which is like cricket or fielding, those things, or it is to do with the basketball or volleyball. Okay, so that again have the risk factors there. Clear? So really appreciate the interest that's shown by the participants. I'm really happy that this many people could listen to me, and that's the success of AOMPT. Okay, so we have a huge following. We have people learning from us from various countries. Okay. So anyone is having any questions, please come forward, put the comments, your queries, so that I can answer. If you don't have any queries, then I am ready to close this session, webinar number 17, the differential diagnosis of wrist and hand. Okay. I'm planning tomorrow morning, 7 to 8, okay, morning AM. I'm going to see for the pelvic pain, and maybe if it gets over in 30-40 minutes, I'll continue with the hip pain, okay, differential diagnosis. So that tomorrow night I will take the knee and the ankle, okay. So rather than taking it late, okay. So it's as per the connectivity. If the connectivity is good, I'm going to finish it off, because these videos can be watched by any time by people. You can have your queries asked as comments, okay. I would always give the priority to our AOMPT members to answer the queries, and also those who purchase the full set of anatomy, biomechanics, physical examination and differential diagnosis, the video package, 260 videos at rupees 2500, okay. So with 10 e-certificates and lifetime reference resource, including anatomy. All the 260 videos have been my teaching videos. So those who purchase that videos will be given first priority, because it is like class, okay. So they have attended, so I am obligated to clarify their doubts, okay. When you actually contact on WhatsApp and you ask me doubts, okay. Otherwise, here you put the queries, and I can always see that how well I can answer them as per my convenience, okay. So good luck to you all. Glad to see you all here. Keep rocking, okay, and wish you a very, very happy new year again in advance, 2021. Make sure that you do justice to the qualification and your level of practice, what you are aiming, okay, by empowering your knowledge. Join AOMPT.